Good evening, everyone, and thank you for joining this Physician Town Hall. We felt it was important to update you on the current state of COVID-19 activity at HHS and the impacts on the medical staff. We've got a formal presentation for you this evening in the first half of the time slot, and the second half we'll open it up for questions. When it is time for questions, we'll get you to use the raise your hand feature on your Zoom screen, and then we'll call upon participants to ask their questions in order. I'll just take a few moments to introduce the speakers this evening. First of all, we have Rob McIsaac, as you know, the President and CEO of HHS, and Rob will provide us some context about our current activity at HHS. We have Dr. Wes Stephen, the EVP Operations and Chief Operating Officer, who's going to talk to us a bit on our capacity planning. I'll provide some update on topics related to physician human resources, and we'll be joined by a guest speaker, Dr. Rick Titus, who's a primary care physician and the District Director of Ontario Medical Association, and he'll update us on some of the physician billing processes where the ministry has provided or is providing through negotiations with the OMA some support for physicians. We have Dr. Catherine Ross, who's the President of the Medical Staff Association, and she'll give us some updates from the MSA perspective. And we have Smita Holder, the Chair of the Medical Advisory Committee, who will give us updates on behalf of the MAC. And in the question period, we'll also have support from Dr. Paul Tannenbaum, who is on the negotiating team from the OMA with the ministry, who may be able to provide any updates on those physician supports. So at this time, I'll hand over to Rob McIsaac to start off the formal presentation.
Okay, thanks very much, Michael, and thanks to everybody on the line for making time to attend this session. I'd like to begin by just acknowledging the terrific contributions of our entire physician team across Hamilton Health Sciences in the face of this pandemic. From my perspective, your leadership and adaptability and your patience have been an essential part of the quick response that our hospital has been able to mount. Should also acknowledge the emotional, ethical, professional strains everyone has experienced in doing this work. Challenges like this one are both personal and professional, and I just think it should be said, this has not been an easy time for any of us. In coping with this pandemic, our response planning has had to deal with a very dynamic situation. Shortages of PPE, lab materials, uncertainty over the shape of the curve of, or the what some people are calling the epicurve, or the prevalence of the virus in our community as it waxes and wanes, and an evolving understanding of the virus itself have made planning and responding to all of this very challenging. I'm sure that for many of you, keeping up with this ever-changing situation has proved very difficult. This effort has been going on for over 8 weeks. We've been trying to ensure that we were creating the most possible capacity should the very worst have occurred in our community. This has been a regional effort guided by an Ontario-wide capacity planning structure led through Ontario Health. HHS has been involved in numerous ways. Many HHS physicians and staff have been leading and informing the province's work. I'm chairing the sub-regional planning effort for the area that was formerly known as the HNHB LIN. And our work there has focused on creating and coordinating capacity for both acute and critical care, PPE supply, distribution, conservation, health human resource planning, and many other aspects of the pandemic response. This work is by no means over, but I think in many respects, this week marks a bit of a change in our approach. While the pandemic locally has not been the kind of forest fire we were trying to prepare for, it does continue to smolder in our community, particularly in congregate settings housing our most vulnerable. So we have begun thinking about a kind of new normal for hospital operations, and we are cautiously pivoting and thinking about resuming some of the clinical services that were paused during the early stages of our response. I think this resumption will be gradual, and we are going to need your input on both the clinical and ethical considerations required as we begin to think about this new normal that I referred to. I don't think we can simply go back to kind of full throttle in operations. We have to reserve some capacity to deal with potential outbreaks of the virus in our community until we get to a reasonable level of immunity within our population. We are also intending on playing a role in ensuring that we are, as a community, safely and appropriately caring for people living in long-term care, transitional care, and retirement homes. We're working closely with the City of Hamilton and Public Health to assist in boosting the resilience of nursing homes and retirement homes in the face of the virus. We'll talk a little bit more today about how we are adapting our planning structures for this new, what feels like an ever-changing new reality. This is going to be a marathon, and it's going to require more conversations like this one to get us over the finish line. I'm looking forward to your questions and to hearing more feedback as all of our work continues. Perhaps I'll stop there and turn it over to others on the line for their contributions. But just in closing, again, my sincere and profound thanks to all of you for what you're doing to help our community, our province, this hospital endure this pandemic. I'm very grateful for all of that. Thank you.
Thanks, Rob. So we'll call now on Dr. West Stephen to give us some comments around capacity planning.
Thank you, Michael. So as Rob mentioned, we're in a continually evolving situation where our surge and capacity planning has to be extremely adaptable and nimble. We continue to work with our local, regional, provincial, and federal partners to ensure we have the appropriate capacity to meet the projected needs. Along with our partners, we continue to monitor the landscape and prepare for the future. At this time, HHS is well equipped to meet the needs of our community and region, thanks to the extraordinary efforts of all of you and everyone at Hamilton Health Sciences. A commonly asked question to us is, what is our current capacity? Well, we've exceeded our provincial targets given to us for April. We have currently approximately 350 beds freed up for COVID patients. This was achieved by significant ramping down of scheduled care. At present, we believe we have more than enough ventilators at 155. And if the demand exceeds this capacity, we do have access to the provincial stockpile that is housed at the McMaster site, as well as loaners and anesthetic machines. But as Rob has mentioned, we are increasingly thinking that the curve is flattening and this tsunami is not likely to occur. We are starting to think about planning of ramping up and starting to resume some scheduled care. But to be clear, this is going to be required direction from the Ontario Health. So maintaining our capacity is an issue, and we know that the intensity of care, the length of stay of ICU for COVID patients, can no longer won't be normal, and they'll be longer, and this has to be factored into our planning. Particularly in those cases that require a planned or unexpected ICU stay. We also have to pay attention to the risk of easing up current measures, particularly public health issues such as physical distancing. Our current state is very much dependent not only on our hospital preparedness, but on how the individuals in our community are responding to these measures. Locally and beyond, we are still seeing a steady stream of COVID positive patients and cases in our institution. We hope to learn more as testing increases and our current models and projections are updated. As always, we ensure ongoing alignment with provincial directives and regional efforts. We have created a great deal of capacity within our walls, thanks to so many of you. At this time, because we feel our hospitals are well equipped to meet the need, there is no immediate need to utilize spaces outside of our hospitals. In recent weeks, we have been in discussions with Rancourt Group about the use of their hotel space on 116 King Street West as an alternative healthcare space for non-COVID patients. Based on provincial direction and local context, we are not pursuing this option at this time, but it remains on the table in event that we need to create some off-site capacity to accommodate a secondary surge of COVID cases. Rancourt has been an outstanding partner and will continue to work alongside of us and other external local partners to address our local needs. Many people from across Hamilton Health Sciences and St. Joseph's Healthcare have been involved in the detailed planning around 100 King Street. Their incredible efforts deserves recognition, and they've been they've achieved much in several weeks' time of work. Thank you to all the medical staff for your involvement in our capacity planning to date. Your expertise and flexibility have been immensely valuable in these unprecedented times. I look forward to answering any questions later in this webinar. Thank you. Back over to you, Michael.
Thanks, Wes. And if we could just go on to the next slide. So firstly, I'd like to echo both Rob and Wes's thanks to all of the medical staff for the fantastic work that people have done, and also for the understanding at this time where much of the work that you normally do has been ramped down in many different areas. I think also early on when we were predicting large numbers of patients, of roughly over 800 ward patients and over 250 ICU patients, we put out a call for physicians to offer to, if they would support by redeployment to the areas in the emerge, ICU, GIM if needed. Nearly 300 physicians put their names forward, which was absolutely fantastic for you to do that and very much appreciated. As it's transpired, we've had to call on very few, if any, of you at this point. That also is supported by CPSO and CMPA, basically putting out statements of support that they would recognise physicians working in different areas, both with their registration component, but also with their medical insurance component, and that would be dealt with post event. So in other words, enabling people to do that and act where necessary. And then there have also been ongoing negotiations between the OMA and the Ministry of Health, looking at some temporary physician funding models. And just over a week ago, we had an announcement of a phase 2 of physician funding, which came out. And at the end of last week, we got some guidelines around how to implement those. And we're not in a stage of surge with COVID patients that would allow us to access many aspects of that. There are some components that contribute to a lot of the planning work, which we will be able to access. But there is ongoing negotiations between the OMA and the MOH. And I'll turn now to Rick Titus just to give us an update on what we can expect to come shortly in relation to that. Over to you, Rick.
Well, thanks, Dr. Stacey. So I'd like to, first of all, introduce myself, Rick Titus. I am your local OMA district rep. I sit on the OMA board, and actually I'm an HHS family physician. I trained in anesthesia in the 1980s. Well, first of all, I'd like to thank you for your commitment and your dedication for all the people in Hamilton. And on behalf of the OMA, we thank you. But we also realize that thanks is just not enough. You know, there's the issue at the end of the day. We have bills to pay, we have offices to run, and I've heard from many of you, and many of you are saying, well, we need fair compensation. So I've had an opportunity to talk to Dr. Susan Reed, Dr. Matthew McCrae, and the message that I'm getting is we need compensation, and we need compensation now. You know, our incomes have fallen 90%. So at the OMA board, we've gone through phase one, and phase one, it's the virtual codes. Now, we were quite pleased when we got the virtual codes. I think many of you are using it, and we've gone from a society where 6% of visits were virtual to the point where we're up to 60%, which is 80%, which is amazing. But the caveat is that they've agreed to the virtual codes, but they're not paying us until June. A real point of frustration at the board, and a real point of frustration for all the doctors of Ontario. The other issue is phase two compensation. It's complex, and I'm really fortunate on this call. I was able to get Dr. Paul Tannenbein. And Dr. Paul Tannenbein will sort of address any questions or issues about phase two. He's the negotiation task force chairperson, so thanks, Paul, for joining us. The next is phase three, and phase three is fair compensation. So this is what the board is looking at right now. I'm not sure if you saw that Toronto Star article that came out on Saturday. Well, I saw it on Saturday morning, and we at the board had never even seen that proposal. So we're not sure where that came from. I hate to say it, but it's like fake news. The board definitely is not in agreement with advance pay, and then you have to pay it back. We're looking at income stabilization. We're looking at infrastructure support. So that's our focus moving forward, and actually we have a board meeting tonight. So again, we'd like to thank you, and we're working hard on your behalf. Any reason and thank you for allowing us to attend today.
Okay, thanks, Rick. So we just go back to the previous slide. Yes, so just to update you on a lot of the work that's happened here at Hamilton Health Sciences, and I think you may or may not be aware of a lot of the effort that's gone on in the key three disciplines of internal medicine, the ED and ICU, where the chiefs and their teams have been looking at models of care that will get us through up to those very high levels of patients that we were predicting, both on the ward and in intensive care. And they've done a fantastic job getting those models set up so that we know that had we gone there, we would be able to certainly easily get through the first three phases, and there are 5 stages to this. The last 2 stages would have been more challenging, but we at least had line of sight of how to manage those patients at that time. And they've been very ably supported by Medical Affairs, and Dr. Helene Flagiol, as our Chief of Pediatric Surgery, has helped with that work as well. But we've also instigated with anaesthesia's planning with Susan O'Leary, intubation teams to support the intubation of patients both in the emerge, the wards and ICU. And they started just this past weekend. And so a lot of work and effort gone on through the teams there. And then just so you're also aware, we've had physician leads involved in the key task forces that have been doing a lot of the preparatory work. So the ambulatory, procedural, capacity, decanting, and resilience and ethics task forces. So we've had Barry Lum, Steve Kelly, Khaled Azam, Mohammed Panju, and Ralph Myers been helping with the resilience and ethics group. We've not seen the influx of patients that was originally considered to be what was coming our way, as is indicated by Rob. But we are now seeing a second issue of not being able to discharge our patients to the long-term care homes or retirement homes. And so we will see a building up of ALC patients. So we're having to plan how to manage that. And there is a possibility that we may see some patients come from those long-term care environments if some of those collapse, but we are setting up, if you like, SWAT teams that was mentioned earlier to try and support them when necessary. And of course, there is the planning ongoing now as to how do we start to bring back some of that normal activity, as both Rob and Wes alluded to, in a manner that's controlled, but still has a mind of keeping some capacity if we get a surge or a second wave that may come to us. So I'll finish there, and I'll hand over to Dr. Kathy Ross, who's the President of the Medical Staff Association, to give a perspective from Medical Staff Association. Kathy, you may be on mute. Kathy, I think you're on mute. There we are.
I'm good. Sorry, the wrong button. Thanks, Michael, and thanks, everybody. So if you actually look at the MSA website under what we do, there are 4 categories: communication, representation, and support, and advocacy, as well as collegiality. And maybe I'll just address some of the things we've been doing under those categories. So, you know, at the very beginning, our problem was a little bit of anxiety and looking for information. And so we soon found out that there was a command center, and all of these task force had been very rapidly mobilized. And so the information soon came really at a rapid pace, kind of like maybe trying to drink water from a fire hose. So at that point, the MSA kind of decided to try to choose bits of information that were of specific interest to physicians and try to deliver it directly to them, because there was a lot of really good information, but just, you know, there's a lot of it. So we did try to do that, and Dr. Stacy participated and helped us to do that. Some of the important things like the Ethics and Resiliency Committee work and the advanced care planning that the primary care people had asked us to send out, as well as things like the protected code blue and stuff. So the MSA is fortunate to have a voice at the Medical Workforce and Redeployment Working Group, and thanks to Dr. Stacy for including us. One thing we have done by way of communication is we've combined with some of the capacity workforce group, and we're putting together a folder that's going to be both on the hub and the website of just resources that are really for physicians, sort of higher level articles about treatment, inpatient, outpatient, and we'll try to add to that. And a little bit benefit of that is if we have it internally, there's a link to get free access to UpToDate, which some of us like to use frequently, but we lost our access to that through our library. And the second thing we're doing is representation. So again, we're on the, we have a non-voting seat at the Medical Advisory Committee, and Dr. Stacy put us on the Medical Workforce Redeployment Working Group. Obviously, this is now going to switch over to the important getting us back to work and doing some of the non-COVID but important and necessary patient care. So that's where sort of leads us into support and advocacy as the MSA. As we potentially open cautiously with this kind of 1 foot on the gas and 1 foot on the brake method, the MSA and the executive hopes to have a voice here to ensure that we have, you know, sort of ethical but also equitable access for our members, so they can get patients in where there's, you know, this new looming chronic issue of pent-up demand for delayed services. And this would be an important part of getting our community back to functional health. There is another aspect to support and advocacy, and it's been referenced by Dr. Titus, and that's the financial aspect. So while there are many physicians at the front line doing their really good work, there's as many kind of waiting in the wings, not really doing anything, and that brings its own set of anxieties and issues. The latest OMA survey respondents showed that 50% of fee-for-service billers have already laid off some staff, with another 20% about to. And many people say their offices will be closed for a few months. So this is not really super conducive to, you know, to do our community care and getting our patients through. So we do need to be part of that so that we get it right going forward, and having that balance of opening up space while keeping our reserve for the potential COVID surge. So the MSA recognizes that all of this has created stress in many ways for many different people for various reasons. So I think it's really important to note that the HHS has done a lot of good work. There are many wellness resources, and I think it's really incumbent upon us as individuals to really take the time to check in and with each other and with ourselves, and take the time to really work on our resilience and wellness. And you know, the OMA also has some very good resources for that, and the MSA is happy to help people that feel the need in any way. The Canadian Medical Association has done a lot of work on physician wellness, and it's not only our individual accountabilities, but certainly healthcare systems have also accountabilities in trying to assist physicians in being engaged and being well. And so hopefully the MSA continues to work with the senior leadership and Dr. Stacey to ensure that as we try to move to our new normal, that we are inclusive and appropriate with all of our physician staff.
Okay, thanks very much, Kathy. And I'll now hand over to Dr. Smita Halder, who's the chair of our Medical Advisory Committee, to give us updates on behalf of the Medical Advisory Committee.
Great. Thank you very much, Michael. I just want to echo the thanks to all the staff that have been helping and working so incredibly hard for the last 6 weeks. There've been huge changes to our work life, and during this extraordinary time, there's been an intense escalation of work in the number of committees that are accountable to the Medical Advisory Committee. And so ordinarily, we would receive the details of any of their meetings and policy updates and approve them just on a monthly basis. And committees such as the Credentials Committee, Pharmacy and Therapeutics, Order Sets, the Regional Infection Control Committee and the Ethics Committee have been meeting much more frequently and developing emergency measures and policies. And so to ensure that all these directives and policies were being reviewed in a timely manner, we decided to set up twice weekly MAC executive meetings. So we've been using the same due diligence to review the policies and making sure that there's been time to discuss them and gain input from the relevant stakeholders, and we've been able to get these through quite quickly and hopefully disseminate the information to you all as soon as we've passed them. We've had one emergency full MAC meeting that was held on April the 1st. That was to approve, mainly to approve the critical care triage protocol, which we felt was extremely important to push through. We've also had meetings with the Credential Committee and Credential staff in a much more fast-track way, so that staff that have been redeployed from their usual place of work to another centre, such as family doctors that were now who are now staffing some of the COVID assessment centres, were able to be credentialed with HHS quickly. And I think we envision continuing with these twice weekly MAC exec meetings for the near future. And I just want to again recognise the amount of work that's been going on in the command centres and command centre meetings and all the background committees. So I'm happy to take any questions about anything that the MAC has been dealing with recently. Thank you.
Thanks very much, Smita, and thanks very much for your efforts at the Medical Advisory Committee, and Kathy with yours on the Medical Staff Association. Much appreciate that. So and I'd like to thank all the speakers really this evening for bringing the important updates that they've done, and we'll open now for questions. So I'll turn it over to Aaron Levo, who's our Vice President of Communications and Public Affairs, and he'll manage the question time. So over to you, Aaron.
Yes, as the person steeped in communications professionally, I have the distinction of moderating our Q&A. So a little bit of housekeeping for everyone. We'll use the raise the hand function. So you can find that inside your Zoom window pane on your computer. And as you raise your hand, then I'll call upon you and you'll get the chance to ask your question of the panelists. And we'll proceed in that fashion and try and get in as many as we possibly can. So let's give this a try. Anyone that does have a question now, please use the raise your hand function and we'll get to your question. Not seeing any at this time. Oh, yes, here we go. I have a question here from Lori Ellett. Please go ahead, Lori.
Can you hear me?
Yes, we can.
When do you foresee moving from urgent cancer surgery to filling up our lists with non-urgent non-urgent pre-cancer surgeries or other such activity in the operating room?
So perhaps I'll take that one to start with. Thanks for the question, Lori. I think that I can't give you a specific date or time. We are looking at 2-week intervals of trying to make some of these decisions. I think that a couple things I would highlight. One is that we are looking at the curve and trying to get a sense of whether we've hit the peak or not hit the peak. And so trying to understand the number of new cases, the doubling time, and the infection control issues surrounding that and is a consideration that needs to be made. Secondly is you've heard already a couple times about having the foot on the gas and the foot on the brake, and it is about trying to ease in the scheduled work and recognizing that we have to maintain some capacity because if there is a second wave, and if we look towards Asia, there are some concerns about when the public health measures start to be lifted, what happens? And so that has to be taken into consideration. And so to answer your question, our current way of thinking is really at 2-week intervals where we're reassessing things. So I can commit that the next couple of weeks, it is unlikely you will see that happening. But as this evolves, we'll have a better sense of it. So I wish I could give you exact dates, but that's not really possible. I don't know if the panelists would like to add anything else.
Wes, I just might make one other comment, Laurie. One other thing that we're having to take into consideration during this planning of how to bring back sort of routine care is the impact of not being able to discharge our patients to long-term care facilities or residential facilities, which means our ALC population of patients within our hospital will simply grow with time. So we're going to have to accommodate that, and we expect that'll be somewhere around about 15 patients a week. And the other unknown is if any of the long-term care facilities or residential homes do run into problems with staffing, there is a risk that we will have to take some of those into the organisation just simply to salvage those organisations where patients have no ability to get care or be looked after. So we don't quite know how those things are going to pan out at this stage. So they're having to be put into that synthesis of understanding. And to Wes's point, we would like to get back to more regular care as soon as we can, but we have to do it in a manner that's respecting all of these different pressures.
Sorry, thanks, Michael. You reminded me of a third point, and that's the PPE story. So the supply chain was pretty precarious a couple of weeks ago, as we all heard. As it starts to firm up, that's encouraging, but we also have to have line of sight that as we increase surgical interventions and other interventions, the demand or the burn rate on our PPE will rise, particularly as more and more people come into the organization, patients and et cetera. So that's another consideration that needs to be factored in as well.
Can I just, maybe I could just mention that I think there is some ability for us to internally start to make some of these decisions, but the province for sure has a role to play in helping us to decide, how much gas we're going to put on and to what extent we'll take our foot off the brake. So I think that there were some revised numbers released by the province today in terms of the curve that they're anticipating going forward. I think it's basically good news for us in terms of the scenario that's played out looks much better than, it's probably the best case scenario we could have hoped for. But we will be looking to the province for some guidance on this issue of how fast to ramp up. And I think we can expect that within the next week or so.
Okay, thank you to our panelists. So I'll move to our next question, please, from Sonia Anand. Go ahead. Go ahead, Sonia.
I think she's on mute.
Okay, sorry. Thanks for your presentations, everyone. I'm wondering if you could describe what your plans are for redeployment to assist long-term care institutions.
Yeah, so I can start, and Wes maybe can supplement. We are working at an Ontario West level. So that's basically the region, down to Niagara, to the north of Waterloo, as far west as Windsor, to develop approaches and strategies for helping to enhance the resilience of long-term care and retirement homes. I anticipate in the next couple of days, I'll be sending out a memo to everybody in the organization, looking for volunteers to help us in a number of ways. I think, the hospitals have to work with the community, public health, and the city most particularly to find ways to help homes that are in crisis. So that means going out and assessing them, and there's thousands of them, across the province. So this is no mean task. Assessing them for how well they're doing in terms of their adherence to infection control, proper infection control procedures and so on. And then also monitoring them in terms of outbreaks and so on. I think where a home gets into trouble, we're, as a hospital, trying to develop resources, including volunteers who might go out to try to help stabilize some of these congregate settings. We'll also be looking for volunteers to go out and help do some training where that's appropriate in proper infection control procedures. This is all relatively recent. It was really only yesterday that Ontario West put out a bit of a framework for how this would look from their perspective. We've been working within the region and within the city to begin to develop our response to all of this. So the design work is still underway in terms of exactly how we'll do this, but we will play a role. It will be in sort of testing, crisis response, and prevention. And I anticipate it'll be rolled out, within a week.
Thank you.
Any of our other panelists like to add?
I think you've covered it well, Rob. The biggest issues are training, PPE, and acute short staff that occurs when there's a significant outbreak where the staff get ill or are not available to come in. So I think you've covered it very well. Nothing to add.
Okay, thank you. Then I'll move to our next question. I have a question from someone whose screen name is Vans Paul. Please go ahead.
Can you hear me?
Yes, we can.
Perfect. I had a comment and then a couple of questions. So our estimates of community prevalence is predicated on widespread testing and up-to-date reporting of test results. And we know that currently public health is not testing people with mild to moderate symptoms of COVID-19. We also know that 50% of all cases are asymptomatic. So the prevalence in our community is much higher than currently estimated. And my question is three-pronged. First of all, I wonder what the plans are for ED cohorting as we see an increase in transfers of patients from long-term care centers, which are sort of epicenters of this pandemic in our community. They're currently contained, but we will see increased numbers of transfers into the hospital. And our ED, as of last week at the General, did not cohort patients by respiratory symptoms or isolation. And secondly, there were areas in which the PPE supply was not adequate. There was also no clear area to don and doff. And I see these as risk factors for infection as we expect transfers into the hospital from these long-term care centers. So I wondered what the plan was and how we are going to match volume with capacity both in the ED. And when I say capacity, it's not just bed capacity, but cohorting of these cases in relative isolation from other areas, and also PPE. And then I had a second part to that question. I'm happy to wait for a response to the first part, if that's okay.
Sure. So maybe I'll start. So the issue of transfer from long-term care homes is one where I would suggest that we have multiple strategies to try to minimize those transfers. So number one is there is a 24/7 telehealth line to ED physicians from long-term care homes. So instead of bringing the patient to the ED, we are in the process of triaging and managing in their setting. That's part of the decanting strategy, and that's work that Mo Panju has led as a physician lead. Number two is the isolation issue in Emerge is recognized, and there is work afoot to try to sort out the cohorting of that. It's not operational yet, but there is work trying to segregate that patient population. With respect to the PPE donning and doffing, I'd have to take that and figure out at the General what the issue is. I'm not that familiar with your concern, but that will be brought forward.
Okay, there's just no clear zone to don and doff, and so you end up risking contaminating clean areas as you get undressed, and also contaminating yourself because there's not an adequate space to do it in a clean manner. The other question I had is about the plan to deal with ramping up of outpatient services and the asymptomatic nature of this infection. I wondered what the capacity was for testing patients and healthcare workers as the outpatient services ramp up and we see possible asymptomatic, mildly symptomatic cases in person in the hospital. I think there's been a level of safety established due to distancing and due to our virtual care modes of delivery that I think have worked well. But as we begin to see volumes increase in the outpatient ambulatory setting and diagnostic testing, how are we going to make sure we do this safely?
So perhaps I'll try that.
Give that to you again, Wes. Yeah.
Thanks. Well, I think a couple realities. Number one is I would suggest to you, like all of us, we would all prefer to have significant more testing done, both in the hospital setting and the community setting. The reality is there is a capacity issue, not just in Hamilton, but in the province, the country, and in the world. And probably the biggest barrier currently is the reagents. That is significantly a challenge for all the labs to actually do. So number two is the on-site. I think really we have to really start thinking about virtual care and that transformation as a long-term strategy rather than a short-term strategy. That's a pretty high comment to make, but the details will need to be sorted out. Number three is you are right about the asymptomatic people coming through the doors, and it will be very much a challenge of when would you test, how would you test? And the other aspect is how do you maintain physical distancing in our ambulatory spaces, in the waiting rooms, in our imaging rooms, etc. So we are turning our minds to the long-term play here of a slow burn rather than a 12-week event, and we need to start thinking that through about ramping up the clinics, and we have to start thinking about virtual care. How do we, recognizing that we have to be at this point strategic with our testing because of a limited resource, and then the physical space issue of people coming through the organization is going to be a challenge. So I'll stop there, and maybe panelists would like to fill in more color.
Yeah, I'll just make a couple of comments, Wes. I mean, I think they're really good points that you raise, Harriet, and they're exactly the types of things that the groups who are starting to look at that are actually considering. And as Wes has said, you know, how do we actually do some of these things, particularly given the impact it'll have on our PPE, the impact on our testing, and then how do we do this? Because this will have to carry on for a prolonged period. It's not just a short period that we'll need to, you know, try and not cause further spread of COVID by patients coming into our ambulatory areas. So the teams are looking at all of that sort of work and considering all of those issues as we speak. But to Wes's point, I think we will see an ongoing effort towards more virtual care for a prolonged period of time. And to be honest, it's not a bad thing. It's probably the new norm. And, you know, I think there's a lot of merit in that. But I don't know if anyone else wants to make any comments.
Yeah, I'd like to make a comment regarding virtual care. So currently the government is supporting virtual care in its present format until the COVID-19 pandemic is over. But at my position at the board is we really have to push for this moving forward. And it's got to be, virtual medicine has to be able to be accessible by all physicians. And right now, when we think about virtual medicine, we think about, you know, using asynchronous messaging, using iPhone, Skype, there's medical platforms, but this is just the edge. For example, now you can use, for example, you can have a setup in a retirement home that has virtual medicine with digital tools. So this is where we're going. So you can actually do a comprehensive examination and looking at the patient, listening to the patient's heart, listening to the lungs, looking at the ears, full exam in the retirement home. And that's where we're looking at, and that's how we can sort of leverage technology to keep the patient safe, but also keep physicians safe moving forward. Also, I might add that there is a home kit now that if you go to Best Buy US, you can get this home kit, which is called TytoCare. With TytoCare, it's $299. You can have a home diagnostic kit that comes with video, and then the physician can direct that patient, put the stethoscope here or there, or look in the ears. So again, we're just showing this, sort of, this is the early days of virtual medicine adoption.
Perhaps my last comment just to this is we have approximately 1 million ambulatory visits a year. So that's the context that we have to sort out of physical testing and having people come through our walls. So it does speak to what Richard just spoke about and what Michael's been talking about. We're going to have to rethink how we do ambulatory care.
Okay, thank you for that. I'll go to our next. We have a question from James Bain. James, please go ahead.
You're on mute, James.
You just have to unmute, I think. Let me see if I can do that for you. Doesn't seem to be working. James, go ahead. Try one more time, James. Let me try this. Can you hear us? Okay, we'll let James work on that. If anyone else has a question, is there anyone that would like to raise their hand? I don't have any other questions raised at this time. Oh, now I do.
Are we there?
Hello?
It's James.
Yes.
Hi, James. Go ahead with your question.
All right, thanks very much. Obviously, virtual care is critically to be adapted, but there is no virtual surgery, and the burden of illness that is burgeoning in our communities, especially some services like my own, who've had over a year waiting list for chronic pain and perpetual pain patients, and we have no access, and because they don't qualify as, for cancer or the urgent designations, how are we going to clear any of this backlog if we don't have a ramping up at some time, because virtual care will not answer that problem?
Yeah, so I'll make a few comments, and then I think Wes looks like he wants to comment as well. That's something we're all very, very conscious of, James, because whether it's the examples that you gave or whether it's other examples like Laurie Allett gave, I think in all different areas there are patients who've already been waiting significant periods and have the prospect of waiting much longer periods, and those are the pressures that are going to have to be examined as we start to bring back care. And for sure, while the whole objective of what we're doing here is to try and limit the impact of COVID on patients, the negative of this is we're actually creating another impact on other patients who are forced to wait and not have their care in a timely fashion. So absolutely having to balance those things. But maybe, Wes, your teams are looking at, how do we bring back routine care and how do we control that? But perhaps your thoughts.
I don't have much more to add other than we do need to think through a recovery plan for how do we deal with patients on wait lists. And I accept your observation that some of the urgent work has proceeded, but lots of the non-urgent, or perceived as non-urgent, but has significant impact on people, hasn't been proceeding. And so that's the pressure to get the ramp up, recovery plans, and then still managing the infection control issues that we have to address. So I know there has been 2 panels provincially. One surgical panel has given advice. There's a second panel that's being developed as well to give input to the government on recovery plans for interventions such as surgery. So your point is well taken. I don't have a quick answer for you today, other than to say that there will be no doubt literature being published in the near future about non-COVID deaths and the morbidity to people for delay in treatment, and not just oncology, which is an issue, but things that you do for a living. So I'll stop there.
Thank you.
Sorry, Richard, did you want to add something?
Yeah, so right now the OMA, as I mentioned, is we're working on phase 3, the fair compensation. The next thing on the horizon is looking at phase 4, and is working with the ministry about ramping up, catching up. What's the next phase, next steps? So we're really happy to get your input. So please send it to us, and hopefully we'll be able to address that.
Thank you. I have our next question from Tatiana Zdravkovic. Please go ahead, Tatiana.
Hello. First, before I start asking questions, I would like to thank you all for doing diligent work and keeping us posted. I'm from physical medicine rehabilitation, and our department has been quite away from frontline issues. Pain management and our patients who are suffering because they cannot get those simple steroid injections is coming to be more obvious, and we know that some of those patients may end up in emergency because they couldn't cope with pain anymore. So yes, we really have to look into how that could be done safely with protective equipment and so on and so forth. But I also have a question, and I'm not sure if anyone of you ever thought about using what's happening to us in looking into mobile team for rehabilitation, where physiatrists with therapists and assistants can go and actually help patients who are already admitted to acute care hospitals to help them, but have to stay there for whatever reason, to try to help them get up on their feet sooner and get discharged home sooner. Will be a nice model to try even for the later on, but also to help patients leave the acute care hospital where the chance of getting maybe COVID could be higher than if they're at home. Thank you.
Okay, thanks, Tatiana, for that comment. Maybe just a quick follow-up question for you. Are you talking about within HHS, or you're talking about in hospitals in the region?
I do work at the Juravinski Hospital. We do have regional rehab center, which is next to the general hospital down in a city. So I'm talking in general for now, us at least.
Right, so even though the regional rehab unit is closed, to provide your teams to go out to the wards to provide that or initiate that rehab for patients. Is that what I'm hearing you say?
Yes.
Yeah, I think that's a good plan and a good thing for us to actually start to think about, you know, during this time, because obviously there are patients who will have conditions that need rehab, and the rehab helps them to get better and, you know, leave hospital sooner. So clearly, keeping that rehabilitation going is very, very important. So we can certainly, I can certainly talk to your chief, Nora Cullen, and discuss that with her.
I know that I do oncology rehabilitation, and I know that probably my oncology patient on C3 and C4, some of them will be benefit from having that our beds are closed for inpatient rehab anyway.
Okay, no, good suggestion. Thank you.
Thank you.
I'm conscious of the fact that we are at time. It is 6 p.m. I do have 4 more questions in the queue, but maybe to be respectful of those that had to sign off, we'll end it there and would suggest, Michael, if it's possible, those individuals can follow up directly with you by email with whatever questions they have, and we'll get them a response as quickly as possible.
Okay, yeah, thanks, Aaron. I think that sounds like a good plan. So I'll just in closing, I'd firstly like to thank all the attendees and the speakers for making time to connect this evening. I'd just like to remind you all that all of the COVID-related updates are available at Hamilton Health Sciences under COVID-19 updates through our website or through our hub. And then from there you go to the staff and physicians areas, which you see on your screen. And to Aaron's point, if you have any additional questions, for sure, feel free to reach out to myself or your department chief, and we'll try and respond to those for you. And if you have any feedback or suggestions on how we can improve the physician experience as we continue through this COVID pandemic, please send those through as well. So once again, thank you everyone for joining this evening, and enjoy the rest of your evening. Thank you.